Welcome to the deep dive. Today we're navigating the fascinating and really intricate world of the ocular motor system. We'll be exploring how even seemingly minor glitches in our eye movements can serve as really significant clues, almost like a secret language, pointing us towards potential neurological issues.
Yeah.
It's quite remarkable when you think about it. These tiny, precisely coordinated movements that we mostly take for granted can actually hold vital information about our overall health.
Absolutely. It's a testament to the, exquisite organization of our nervous system. And just to make sure we're on the same page right from the start, let's clarify a couple of terms.
Okay.
When we talk about ocular motor, think of it as the umbrella term.
Mm-hmm.
It covers the 3 cranial nerves that directly control eye movement.
Mm-hmm.
It's cranial nerve, 3, the oculomotor nerve,
Right.
4, the trochlear nerve, and 6, the abducens nerve.
Got it.
Now, the term oculomotor specifically refers only to cranial nerve 3.
Oh,
And this distinction, which, experts like Lee and Z really emphasize, it becomes pretty important as we delve into the specifics of different conditions.
right. And it's not just in routine examinations either. Our sources point out the particular power of ocular motor assessments in critical situations, like, say, when a patient is comatose.
Exactly.
In those moments, these subtle signs can offer some of the most crucial insights into the underlying neurological status.
Precisely. So the mission for this deep dive is pretty clear. We're going to systematically investigate the strong and often very direct relationship between various abnormalities in ocular motor function and the precise location of the underlying issue.
Okay.
These issues, or lesions as they're often called, can crop up anywhere within the nervous system, from the higher cortical centers down through the brainstem, affecting the cranial nerves themselves along their paths, or even residing right within the eye muscles. We'll be using our provided text as a roadmap, really, to unpack this fascinating connection.
Okay, sounds like a plan. Let's jump right into something that might sound a little contradictory at first. Monocular diplopia. Now, we all kind of know diplopia as double vision, right? Seeing 2 of something when there should only be 1. But monocular diplopia, that's seeing double, even when you've only got one eye open. How does that even happen?
Yeah, it does seem counterintuitive, doesn't it? But it's a real phenomenon. And it's important to understand that this isn't always a clear, sharply defined doubling of the image.
Okay.
Often, especially when the underlying issue is relatively mild, people might just perceive a general blurriness rather than 2 distinctly separate images.
So if someone describes blurry vision in just one eye, how would you even figure out if it's this monocular diplopia? What's the test for that?
Well, the key is to isolate each eye individually.
Right.
If the blurry vision or that sense of a second image persists when the unaffected eye is covered,
Okay.
but then completely goes away when the affected eye itself is covered, that's a really strong indicator of monocular diplopia originating in that eye.
Interesting. So covering the good eye doesn't change anything, but covering the seemingly problematic eye fixes it. And what does this second sort of ghost image typically look like? Is it clear?
Not usually, no. It's often described as being less clear than the primary image, almost like a faint, partially transparent ghost image,
Okay.
or maybe a halo that's superimposed on or just slightly offset from the main image.
A halo, yeah, you hear people mention that sometimes. Now, our sources mention that using a pinhole can dramatically reduce these symptoms. Why is that such a telltale sign?
Okay, think of a pinhole like a very narrow filter for light.
Right.
In many cases of ocular monocular diplopia, the problem lies in irregularities or maybe opacities within the cornea or the lens of the eye. These imperfections cause incoming light rays to scatter in multiple directions, and it's this scattered light that creates the additional blurry images.
I see.
By looking through a pinhole, you significantly reduce the amount of this scattered light entering the eye. The pinhole essentially forces the light to pass through a much smaller, central, and often more regular area of the cornea and lens,
Right.
minimizing the distortion and resulting in a much clearer single image. So a dramatic improvement with a pinhole strongly suggests the problem is optical within the eye itself.
That's a really clear explanation. So if the pinhole works, it's likely an eye issue. Our text mentions a whole range of potential ocular causes in Table 8.1. Can we touch on some of the common ones?
Absolutely. Table 8.1 details various conditions within the eye that can lead to monocular diplopia. This includes corneal problems like astigmatism.
Right, where the cornea isn't perfectly round.
Exactly. Or opacities, things that cloud the cornea. Similarly, irregularities or opacities in the lens, the lenticular astigmatism or opacities can do it too.
Okay.
Even something as simple as a tiny foreign body trapped in the aqueous or vitreous humor, the sort of jelly inside the eye, that can disrupt the light path. Various retinal diseases can also manifest this way.
Really? Retinal issues too?
Yep. And interestingly, even after ocular surgery, changes in the eye's optics can sometimes lead to this.
Yeah.
And while we typically associate it with binocular issues, certain types of strabismus eye misalignment can occasionally cause monocular diplopia.
Wow.
And maybe surprisingly, the table even lists psychiatric conditions as a potential cause.
Psychiatric. That's quite unexpected. How might a mental health condition lead to someone seeing double out of one eye?
Well, in some psychiatric conditions, individuals can experience a range of unusual visual perceptions.
Okay.
And this could include the sensation of double vision in one eye, even when there's no underlying physical abnormality in the eye itself. It's considered a functional visual disturbance, a manifestation of their psychological state, rather than a problem with the eye's optics or the visual pathways.
That really underscores the importance of, considering the whole picture. Now, the text briefly mentions how things like refraction, getting glasses, or artificial tears, or contact lenses might help address some of these ocular causes.
Yes, exactly. For example, refractive errors like corneal or lenticular astigmatism are a pretty common cause of optical distortion.
Right.
And these can often be effectively corrected with glasses or contact lenses, which basically reshape the way light focuses on the retina.
Makes sense.
Artificial tears can help to smooth out minor surface irregularities of the cornea, especially if dryness is a factor in scattering light.
Okay.
And in some cases, a rigid gas permeable contact lens can provide a new, more regular front surface for the eye, especially if the cornea is irregularly shaped. That can lead to improved clarity and reduce the monocular diplopia.
Okay, so that gives us a good handle on the ocular side of monocular diplopia, the problems within the eye itself. But then the text introduces a completely different beast, cerebral polyopia. That sounds more complicated.
It is. Cerebral polyopia is another form of monocular diplopia, but unlike the ocular type, its origin lies in the brain, specifically in the visual processing areas.
Okay.
Several research studies have looked into this fascinating and relatively rare phenomenon.
And what are the key ways to tell this brain-based monocular diplopia apart from the eye-based kind we were just discussing? They both happen with one eye open, right?
They do, but there are crucial distinctions. First, in cerebral polyopia, people typically report that all the multiple images they see have equal clarity.
Okay. Not a ghost image.
Exactly. Very different from ocular monocular diplopia, where the second image is usually fainter, less distinct, like a ghost or halo.
Got it.
Second, and this is a really important differentiating factor, a pinhole will not resolve or significantly improve the multiple images in cerebral polyopia.
Right, because the problem isn't optical scattering in the eye.
Precisely. Remember, the pinhole usually provides significant relief for the ocular type.
So the pinhole test is a clear fork in the road for diagnosis. What else helps distinguish cerebral polyopia?
Another key feature is that the appearance of the multiple images stays the same whether the person is viewing with just one eye or with both eyes open.
Okay.
That strongly suggests the problem isn't in the eyes themselves, but in how the brain is processing the visual information it gets.
Makes sense.
Furthermore, the number of images perceived can vary quite a bit. Some might see just 2 images, while others describe seeing many, sometimes even arranged in a grid-like pattern.
A grid, wow.
Yeah, this latter phenomenon has been colorfully described as entomopia, or insect eye.
An insect eye view, that's quite a striking description. Now, since it's originating in the brain, are there usually other neurological signs that come along with cerebral polyopia?
Very often, yes.
Yeah.
Because cerebral polyopia typically results from damage to the occipital or parieto-occipital lobes, the visual processing centers.
Right.
Patients frequently show other signs of dysfunction in these regions. These can include things like homonymous visual field defects.
Meaning they lose vision in the same half of the visual field in both eyes.
Correct. As well as difficulties with visually guided reaching. They might struggle to coordinate hand movements accurately with what they see.
That makes sense, given that those brain areas are so heavily involved in integrating visual input with motor output. What other associated neurological signs might we look for?
We might also see things like cerebral achromatopsia or dyschromatopsia, basically, problems perceiving colors correctly,
Okay.
or object agnosia, which is the inability to recognize familiar objects even though you can see them clearly. Some individuals might also experience abnormal visual afterimages.
So a whole cluster of higher-level visual processing issues could be present. And our text mentions that these multiple images often appear in the visual field that is opposite to the side of the brain lesion.
That's a really valuable clue for localization. For instance, if the lesion is in the left occipital lobe, the multiple images might be predominantly seen in the right visual field. This contralateral representation is a hallmark of how the visual cortex is organized.
Finally, what are some of the common underlying medical conditions that can actually lead to cerebral polyopia?
Cerebral infarction, a stroke affecting those occipital or parieto-occipital areas, is the most frequent cause.
Okay.
But it can also happen with brain tumors located in these regions, multiple sclerosis, encephalitis, which is inflammation of the brain, seizures,
Seizures, too.
yes, and even as a manifestation of migraine sometimes.
So quite a range of potential neurological issues that can disrupt our brain's ability to process a single clear image. Now let's shift our focus to the more, shall we say, commonly understood form of double vision, binocular diplopia.
Right. Binocular diplopia, as the name suggests, is seeing two images when both eyes are open.
Okay.
And as our text points out, this type of double vision most often indicates some form of abnormality in the extraocular muscles, those 6 little muscles that control eye movement and alignment.
That makes intuitive sense. If the two eyes aren't perfectly aligned, they'll each send a slightly different image to the brain, and the brain interprets that as seeing double. But our text does mention a rather unusual exception to this rule.
Yes, that's the phenomenon called hemifield slide or slip.
Hemifield slide.
It's a relatively rare cause of intermittent binocular diplopia that can occur in some patients who have lesions affecting the optic chiasm.
The optic chiasm, right, that's the critical junction where the optic nerves from each eye partially cross over before heading back to the brain. So how can a lesion there cause double vision without involving the eye muscles directly?
Well, this phenomenon typically arises in individuals who have complete or nearly complete bitemporal hemianopic visual field defects.
That's tunnel vision, essentially. Loss of the outer peripheral vision in both eyes.
Exactly. The underlying mechanism involves a disruption of ocular fusion, the brain's ability to merge the images, which can then lead to a decompensation of a pre-existing phoria.
Aphoria, okay, you mentioned that term. We'll define that more formally a bit later, I think.
We will, yes. But for now, the core problem leading to this hemifield slide is the loss of true binocularity, especially in the central visual field.
Well,
When the optic chiasm is significantly damaged like this, the brain essentially gets two independent, sort of free-floating visual hemifields, one from each eye, with very little overlap right in the middle.
I see.
Each eye is mostly projecting visual information to its own side of the brain. This lack of corresponding points in the visual field makes it extremely difficult for the brain to merge the two images into a single cohesive picture.
And what kinds of visual complaints do these patients typically have then?
They often report experiencing intermittent double vision. And they tend to find near vision tasks, things like threading a needle or detailed sewing, particularly challenging.
Right.
But interestingly, when they have a standard ocular motor exam, despite complaining of double vision, there's usually no objective evidence of an actual weakness or paralysis of their eye muscles.
So the muscles themselves are working okay, but the brain is struggling to integrate the input from the two eyes because the fields don't overlap properly anymore. Our text then explains the mechanism a bit further in the context of esotropia and exotropia eyes turning in or out. Can you elaborate?
Certainly. If a person has an intermittent tendency for their eyes to converge inward, that's esotropia, when the brain's ability to fuse the two hemifields breaks down, a sort of blank space can appear between the vertical center lines of the two visual fields as they drift apart horizontally.
Okay.
Conversely, if there's an intermittent tendency for the eyes to diverge outward exotropia, the vertical center lines can actually overlap. This causes a superimposition of images that come from non-corresponding areas on the two retinas.
So it's essentially a problem with how the brain is interpreting and trying to align these now largely separate visual fields. And our text also notes that this hemifield slide diplopia can even occur in individuals with altitudinal visual field defects, like losing the top or bottom half of vision.
That's correct. Any significant and incongruous disruption, the corresponding areas of the visual fields from the two eyes, can potentially lead to this somewhat unusual form of binocular diplopia, even if it's not that classic bitemporal pattern.
Okay, interesting. Let's move on to the more typical causes of binocular diplopia, the ones that do involve issues with the eye muscles or the nerves controlling them. Our text first discusses horizontal binocular diplopia. What's the key characteristic patients report?
Patients with horizontal binocular diplopia will describe seeing two images of the same object positioned side by side.
Okay.
This type of double vision is usually a result of a problem affecting either the medial rectus muscles, which turn the eyes inward, and/or the lateral rectus muscles, which turn the eyes outward. It could also stem from issues with the cranial nerves innervating these muscles. That's cranial nerve 3rd for the medial rectus and 6th for the lateral rectus.
Right.
Or problems at the neuromuscular junction, where the nerve signal actually gets to the muscle. Less commonly, it can be due to issues with the brain's higher-level mechanisms controlling convergence and divergence.
And how might the amount of separation between these two side-by-side images change depending on where the person is looking? Does it vary?
It can, yes. The degree of separation can either vary depending on whether the patient is looking at something far away or something up close, or it might remain relatively constant.
Okay.
For example, take a left abducens nerve palsy that weakens the ability of the left eye to move outward. In that case, the horizontal separation of the two images will typically be greatest when the patient looks at a distant target,
Right.
and also when they try to gaze to the left, which is the direction of the weakened muscle's action.
That makes sense. The weaker muscle struggles most when it's called upon to work harder for distance vision and in its primary direction of movement. Now, what about vertical binocular diplopia? What's the main way patients describe that?
With vertical binocular diplopia, the patient will report seeing two images, but one is positioned either directly on top of the other or maybe slightly diagonally displaced.
Okay.
This type of diplopia often points to an underaction or weakness of one or more of the vertically acting extraocular muscles.
And there are quite a few of those, right?
There are. The superior rectus and inferior rectus muscles, which primarily lift and lower the eyes when they're turned outward, and the superior oblique and inferior oblique muscles, which primarily lower and lift the eyes when they're turned inward.
Got it. And can the difficulty with near versus distance vision give us any more specific clues in cases of vertical diplopia?
Yes, it can. If a patient with vertical diplopia notices their double vision gets noticeably worse when they try to focus on something up close, it might suggest an impairment of the medial rectus muscle, which is key for convergence, or a problem with the oculomotor nerve, CN3 itself, which controls that muscle. It could also point to an issue with the brain's convergence system. On the other hand, as we discussed, weakness of the abducens nerve, CNVI, usually causes horizontal diplopia that's worse at distance.
Right.
Interestingly, if vertical diplopia specifically worsens when looking at near objects, it can sometimes suggest a weakness in one of the oblique muscles.
So the specific gaze direction and viewing distance that make the diplopia worse can be really informative in narrowing down which muscle or nerve is involved. Now, our text introduces the important concepts of aphoria and tropia in relation to eye misalignment. Can you clarify those for us?
Certainly. When we talk about eye alignment, we need to consider whether the misalignment is apparent when both eyes are open and trying to focus, or if it's only a latent tendency that's usually kept in check.
Okay.
Aphoria refers to this latent tendency for the eyes to deviate from perfect alignment when one eye is covered and isn't participating in binocular vision.
So it's hidden normally.
Exactly. The brain's natural drive for fusion, seeing a single image, usually keeps this latent misalignment under control when both eyes are open. However, if there's an actual manifest misalignment of the visual axis that's present even when both eyes are open and trying to fixate on the same target, that's called atropia, or more commonly strabismus.
Okay, so aphoria is like a hidden misalignment, always lurking but usually controlled, whereas atropia is an overt, visible misalignment. And strabismus is the general term for any condition where the eyes aren't properly aligned. Our text then breaks down the naming of strabismus based on the direction of the eye's deviation.
Yes. If one eye turns inward towards the nose, that's called esodiviation.
Es for inward.
Right. If it turns outward away from the nose, it's exodeviation.
And exo for outward.
Correct. A hypodeviation means one eye is positioned lower than the other,
Hypo, lower.
while a hyperdeviation means one eye is higher.
Hyper, higher. Got it.
And finally, if one eye is rotated around its visual axis, that's termed cyclodeviation.
Cyclo for rotation. Okay. And we also have the distinction between comitant and incomitant strabismus. What's the significance of that?
Comitant strabismus is characterized by a deviation, the amount of misalignment, that remains relatively constant regardless of the direction of gaze.
So it's the same amount of turn no matter where they look.
Pretty much, yes. This type is most commonly seen in childhood strabismus.
Okay.
In contrast, incontinent strabismus is when the amount of deviation varies depending on which way the patient is looking. Acquired strabismus in adults is more often incontinent, frequently because it's caused by a specific weakness or paralysis of a particular extraocular muscle or the nerve controlling it.
So incontinent strabismus in an adult is often a bit of a red flag for a more recent localized neurological or muscular problem. Now, let's circle back to that term, phoria. Our text mentions it's a latent misalignment kept in check by fusion. Can you explain a bit more about what this process of fusion actually entails?
Sure. Fusion is the brain's really remarkable ability to take the slightly different images it receives from each eye and merge them into a single three-dimensional perception. This process has both sensory and motor components. Sensory fusion refers to the cortical processing in the brain that integrates the two retinal images into one.
Okay.
Motor fusion, on the other hand, involves the subtle, automatic adjustments our eye muscles constantly make to maintain the alignment of our eyes on the object we're looking at.
So the muscles are actively working to keep things lined up.
Constantly. This precise alignment ensures that the images from both eyes fall on corresponding points on the retinas, which is essential for the brain to successfully fuse them.
So our eyes are constantly making these tiny, unconscious adjustments. And how does aphoria, this latent misalignment, potentially become a manifest tropia then?
Well, aphoria represents that underlying tendency for the eyes to drift out of alignment when the stimulus for fusion is removed, like when you cover an eye.
Right.
As long as the brain's fusion mechanisms are strong and working effectively, they can overcome this tendency and maintain alignment when both eyes are open. However, if fusion weakens or breaks down.
Why might that happen?
Oh, various reasons. Fatigue, stress, illness, maybe the development of a neurological problem that disrupts eye muscle control.
Okay.
If fusion falters, a pre-existing phoria can decompensate. This means the brain can no longer effectively keep the latent misalignment in check, and the phoria can then become an intermittent or even a constant tropia, a manifest strabismus, where the misalignment is visible even with both eyes open.
That all makes perfect sense. So now we have a much clearer understanding of the different types of diplopia and eye misalignments. Our text then moves on to discuss subjective testing for diplopia. Why is this type of testing so crucial?
Well, while a really significant weakness or paralysis of an eye muscle might be quite obvious just by looking.
You can see the eye isn't moving, right?
Exactly. But in many other cases, the findings can be much more subtle. Subjective diplopia testing gives us the patient's own perception of the double vision. It provides critical information about the relative positions and separation of the two images, which really helps us to pinpoint the specific muscle or nerve that might be involved.
And what are some of the primary tools and techniques clinicians use for this kind of subjective testing?
One common and simple method is using a red glass filter over one eye.
Okay.
Because the brain sees the images through the red filter as distinct, it allows the patient to identify which of the two images they're seeing belongs to which eye based on color.
Makes sense.
Another basic technique is the alternating cover test, where the examiner covers one eye then the other, asking the patient about the double images in different gaze directions. But for a more definitive and controlled separation, a very useful tool called the Maddox rod can be used.
A Maddox rod, right? We mentioned that briefly. Can you remind us exactly what it does and how it helps?
Certainly. A Maddox rod is basically a handheld device with a series of parallel cylindrical lenses, usually red.
Okay.
When you look at a point of light through it, these lenses distort the light so it appears as a long red line or streak oriented perpendicular to the cylinders. So if you place the Maddox rod over one eye, while the other eye looks directly at the light source, you've effectively turned that single light into two very different targets, a point and a line.
Right.
This big difference makes it much easier for the patient to dissociate them and accurately describe their relative positions horizontally and vertically. It lets the examiner precisely assess even subtle misalignments.
That sounds like a very clever way to tease out even minor deviations. Once we have these two distinct images, maybe a red line and a white light, how do we use the patient's description of their relative positions to help diagnose the problem? Our text mentions two key rules.
Yes, two fundamental rules that guide interpretation. First, the greatest separation between the two perceived images occurs when the patient looks in the direction of action of the weak extraocular muscle.
Okay, look towards where the muscle should be working hardest.
Exactly. Second rule, In that specific gaze position where the image separation is maximal, the image that appears more peripherally in the patient's visual field corresponds to the eye with the poorer motility, the eye with the weaker muscle.
Those sound like really crucial principles for figuring out which muscle isn't pulling its weight. Our text notes that weakness of the lateral or medial recti muscles, the horizontal movers, can often be diagnosed pretty easily using these rules. How do these same rules apply when we're dealing with palsies affecting the vertical movers? It seems more complex with up-down movements.
The underlying principles are the same, but yeah, you have to consider the actions of all 8 muscles involved in elevation or depression, 4 in each eye.
Right. Superior inferior rectus, superior inferior oblique.
Correct. When there's a weakness in one of these, the greatest vertical separation between the 2 images will be seen when the patient tries to look in the direction where that specific weak muscle is supposed to be working most strongly.
Okay.
Also, a key point for vertical diplopia. The eye that is lower in its resting position, the hypertropic eye, will always project the higher of the 2 perceived images.
The lower eye sees the higher image. Got it. And our text then outlines a recommended 3-step procedure for systematically evaluating vertical diplopia using these principles. Can you walk us through those steps?
Sure. Step 1 is crucial. Determine which eye is sitting higher than the other when the patient is looking straight ahead in primary position.
Okay.
For example, if the right eye is higher than the left, we call that a right hypertropia. Or you could say left hypertrophy, same thing.
Right.
This initial finding tells us there might be a weakness in one of the muscles that normally depress the right eye, right inferior rectus or right superior oblique, or a weakness in one of the muscles that normally elevate the left eye, left superior rectus or left inferior oblique. It narrows the field.
Okay, that's step 1. Identify the hypertropic eye and the 4 potential culprits. What's step 2?
Step 2 is to have the patient look both to the left and to the right. We then observe if the vertical separation between the 2 images increases in either horizontal gaze. So, sticking with our example of a right hypertropia, if we notice that the vertical separation gets worse when the patient looks to the left, this helps narrow it down further. It suggests a potential weakness of either the right superior oblique muscle or the left superior rectus muscle.
Why those 2 specifically when looking left?
Because those 2 muscles have their primary vertical actions when the eye is turned inward or adducted. For the right eye, adduction happens on left gaze. For the left eye, adduction happens on right gaze. Since the right hypertropia worsened on the left gaze, it points towards the muscles that either depress the right eye when adducted, right superior oblique, or elevate the left eye when abducted, left superior rectus. Wait, let me rephrase that slightly. The hypertropia worsening on left gaze implicates the muscles that are primarily active vertically in that position. The right eye's depressors when adducted, SO, or elevators when abducted, SR, and the left eye's elevators when adducted, IO, or depressors when abducted, IR. So if right eye is high on left gaze, it's weak right SO or weak left SR.
Okay, got it. It narrows the possibilities based on which horizontal gaze makes the vertical split worse. And the critical 3rd and final step to really pinpoint the specific weak muscle.
The 3rd step is to have the patient look both up and down, specifically when their eyes are turned in the horizontal direction where the vertical separation was found to be greatest in step 2.
So in our example, looking left.
Right. If we then observe that the vertical separation becomes even more pronounced when the patient looks down while still gazing to the left, this strongly suggests that the right superior oblique muscle is the culprit.
Why?
Because the superior oblique muscle is the primary depressor of the eye when the eye is adducted or turned inward, which is exactly what the right eye is doing when looking left and down.
Ah, okay. That systematic 3-step approach sounds incredibly helpful for isolating the precise muscle causing vertical double vision. Our text also mentions the Bielschowsky head tilt test as another valuable tool here, particularly for oblique muscle function.
Yes, the Bielschowsky head tilt test is very important, especially when we suspect a palsy of one of the oblique muscles, particularly the superior oblique.
How does it work?
The test involves having the patient tilt their head first towards one shoulder, then towards the other, while the examiner watches for any change in the vertical alignment of the eyes.
Okay.
In the case of a weak superior oblique on one side, tilting the patient's head towards the side of the weakness will typically cause an increase in the vertical separation of the images.
Tilting towards the bad side makes it worse.
Generally, yes. Conversely, when the head is tilted to the opposite side, the vertical misalignment may actually decrease, and sometimes the 2 images might even merge into one.
What's the physiology behind why head tilting affects vertical alignment in oblique palsies?
Okay, normally when we tilt our head, our eyes automatically counterroll slightly in the opposite direction to help keep our view of the world level.
Right, the vestibulo-ocular reflex.
Part of it, yes. This counterrolling involves coordinated action from several muscles, including the superior rectus and superior oblique of one eye, and the inferior rectus and inferior oblique of the other. Now, if the superior oblique on one side is weak, when the head is tilted towards that side, the superior rectus muscle on that same side will still try to elevate and rotate inward the eye as part of the normal response. But because the counteraction from the weak superior oblique is insufficient, this disrupts the normal balance. It leads to an increased vertical misalignment typically. The affected eye moves up, where the other eye seems relatively lower. So a right superior oblique palsy gets worse on right head tilt.
So the brain's attempt to compensate for the head tilt actually reveals the weakness. And our text specifically notes that diplopia from a right superior oblique palsy is often compensated by the patient unconsciously adopting a leftward head tilt.
Exactly. Patients with a chronic right superior oblique palsy will often tilt their head away from the affected side toward the left shoulder to minimize the vertical diplopia. This is why it's so important for clinicians to just observe the patient's natural head posture. A consistent head tilt, especially with complaints of vertical diplopia, should always make you suspect a potential palsy of one of the vertical or oblique muscles.
That's a really key clinical observation. Now, we've spent some time discussing subjective testing, what the patient perceives. Our text then emphasizes the crucial role of objective testing for ocular motility as well. Why is it so important to complement the subjective findings with objective measurements?
While the patient's subjective report gives us invaluable clues about direction and circumstances, objective testing lets us directly observe and quantify the actual limitations in eye movement.
Right, what we can see as examiners.
Exactly. This is critical for confirming the subjective complaints and for further pinpointing the specific muscle or nerve. Sometimes a patient might not be fully aware of their eye movement limits, or their description might not be entirely precise. Objective testing gives us measurable data for a more accurate diagnosis.
And what is the primary objective test highlighted in our text for assessing ocular motility?
The alternate cover test, which is nicely illustrated in Figure 8.2, is really a cornerstone of the objective assessment.
How does that work?
The examiner has the patient fixate on a target. Then, you alternately cover one eye and then the other, while carefully watching the movement of the uncovered eye as it picks up fixation.
Okay.
You also pay close attention to what the eye does when you remove the cover from it. Any refixation movement of either eye indicates a misalignment.
Our text mentions primary and secondary deviations in the context of the alternate cover test. Can you clarify the difference?
Sure. The primary deviation is the angle of misalignment when the paretic or weaker eye is the one doing the fixating and the sound non-paretic eye is covered.
Okay, weak eye looking.
Right. The secondary deviation is the angle observed when the sound eye is fixating and the paretic eye is covered.
Sound eye looking.
Correct. And a really important principle, Haring's law of equal innervation, comes into play here. It basically says that when the brain sends a signal for one eye to move, an equal signal goes to the corresponding muscle in the other eye. Because of this, in cases of paralytic strabismus from muscle weakness, the secondary deviation is typically larger than the primary deviation.
Why is the secondary deviation usually larger? That seems a bit counterintuitive.
Think about it this way. When the sound eye is fixating and the paretic eye is covered, if the brain needs to send a strong signal to move that sound eye, say, far to the left, Haring's law says that same strong signal also goes to the weakened muscle in the covered paretic eye.
Right.
But because that muscle is weak, it can't generate the same amount of movement as its counterpart in the sound eye. This discrepancy in response leads to a larger degree of misalignment when the sound eye is fixating. The brain is essentially overdriving the weak muscle, trying to get the good eye to move.
Okay. That explanation of Haring's law makes sense now.
Yeah.
And our text also mentions the term movement of redress. What does that refer to in the alternate cover test?
Movement of redress, or refixation movement, is the corrective movement the eye makes right after the cover is removed from it. If an eye was misaligned while it was covered, due to aphoria or tropia, when you uncover it, it needs to move to reestablish fixation on the target.
Right.
The direction, the speed, and even whether this refixation movement occurs at all gives valuable information about the presence, direction, and rough size of the eye deviation.
And these deviations we observe during the alternate cover test can actually be measured and quantified using prisms, right?
Absolutely. Prisms are special lenses that bend light. by placing a prism of the right strength in front of the deviating eye, with its base oriented appropriately. You can redirect the light path so the eye no longer needs to move when the cover is switched. The strength of the prism that completely neutralizes this movement is a direct measure of the misalignment, usually expressed in prism diopters.
Our text also points out that the alternate cover test is integrated into both the 3-step vertical deviation assessment and the Bielschowsky head tilt test we discussed earlier.
Yes, absolutely. It's a fundamental part of those maneuvers. In the 3-step test, we use it to objectively determine which eye is hypertropic in different gaze positions.
Right.
And in the Bielschowsky test, we use it to observe and often measure how the vertical deviation changes with head tilt. The pattern of change is crucial for differentiating oblique versus rectus muscle palsies.
Now, moving beyond the alternate cover test, our text also mentions assessing ductions and versions. What do those terms mean in terms of eye movements?
Sure. Ductions refer to the movement of each eye individually. Monocular movements.
Okay, one eye at a time.
Right. Abduction is outward movement, adduction is inward, elevation is up, depression is down. Versions, on the other hand, are conjugate movements, both eyes moving together in the same direction simultaneously.
Like looking left or right or up or down together.
Yeah, exactly. Looking left is a version involving abduction of the left eye and adduction of the right. Systematically assessing both the full range of ductions for each eye alone and the coordinated versions of both eyes together helps us figure out if a limitation is due to a specific muscle problem in one eye, or if it's an issue with the nerve supply or the supranuclear control systems coordinating both eyes.
And our text provides a specific guideline for assessing normal lateral excursion, how far outward the eye should move by observing the corneal limbus relative to landmarks.
Yes, that's a useful clinical observation point. When assessing abduction, the outer edge of the iris, the corneal limbus,
The edge of the colored part.
right, it should ideally reach the outer corner of the eye, the outer canthus, when fully abducted. If you can still see white sclera between the limbus and the canthus, it suggests limited abduction.
Okay.
Conversely, for adduction, looking inward, you can look at the limbus relative to the lower lacrimal punctum, that little tear duct opening. In primary gaze, a vertical line through the punctum should roughly hit the border between the inner third and outer 2/3 of the cornea. Significant deviation from that might suggest issues, though it's a rough guide.
That gives us some practical visual cues. Finally, for objective testing, our text mentions the double Maddox rod test again, this time for measuring ocular torsion. How is that done objectively?
Right. The double Maddox rod test objectively measures cyclotorsion, that rotational misalignment.
Okay.
You use 2 Maddox rods, one in front of each eye, with their cylinders oriented vertically. The patient looks at a horizontal line of light.
Okay.
Each eye sees that horizontal line as a vertical red streak because of the Maddox rods. If there's torsion, the 2 vertical red lines will appear tilted relative to each other.
Not parallel.
Exactly. The examiner then rotates one of the Maddox rods until the patient reports the 2 lines are perfectly parallel. The amount you had to rotate the rod gives you an objective measurement of the degree of cyclotorsion.
So, by using these specialized lenses and getting the patient to align the streaks, we can objectively quantify rotational misalignment. Okay, that brings us to the end of our discussion on subjective and objective testing for diplopia in ocular motility. Now, let's shift gears slightly. Our text moves into childhood strabismus. Why is that relevant when we're primarily focused on acquired neurological issues causing diplopia, often in adults?
That's a good question. It's relevant primarily because long-standing childhood strabismus, or a decompensation of it, can sometimes be confused with newly acquired causes of diplopia in adulthood.
Okay, so someone might have had a subtle issue since childhood that only becomes noticeable later in life?
Exactly. Or they might present with what seems like a new onset of double vision, but a careful history and examination reveals features more typical of a long-standing, possibly decompensated childhood strabismus. Understanding the common types of childhood strabismus helps differentiate them from acute neurological events.
Makes sense. Table 8.4 in our text lists various types. Can we briefly touch on the common features of childhood esotropia eyes turning inward?
Sure. Childhood esotropia, often noticed early and sometimes called crossed eyes, is frequently committant, meaning the inward turn is roughly the same in all directions of gaze.
Okay.
A key concern with early onset esotropia is the potential development of amblyopia, or lazy eye, in the turned eye if it's not corrected.
Right. The brain starts to ignore the input from the misaligned eye. What are some common causes of this committant childhood esotropia?
Several possibilities. Significant hyperopia, or farsightedness, is a common one. The child overconverges their eyes in an effort to focus clearly.
Ah, the accommodative effort pulls the eyes in.
Precisely. It's called accommodative esotropia. There can also be issues with the accommodation or convergence mechanisms themselves, independent of refractive error.
Got it. And the text also mentions non-committant childhood esotropias, where the turn isn't the same in all directions.
Yes, though less common than the committant types. These include things like A-pattern and V-pattern essodeviations, where the inward turn is noticeably worse when looking up, A-pattern, or down, V-pattern. There are also specific conditions like retraction syndromes, such as Duane syndrome, which involve abnormal nerve wiring to the eye muscles. And mechanical restrictive causes, like congenital fibrosis of the medial rectus muscle, can physically limit outward movement, causing an esotropia.
Interesting. And what about nystagmus blockage syndrome? That sounds intriguing.
Yeah, that's a specific situation where a child has congenital nystagmus, involuntary eye oscillations. They may develop an esotropia because converging their eyes actually dampens or reduces the nystagmus, improving their vision somewhat.
So the eye turn is actually a compensatory mechanism in that case?
In a way, yes. Table 8.4 lists various types, broadly categorizing the committant ones into accommodative types, related to focusing effort, and non-accommodative types, like infantile or later acquired forms.
Okay. And briefly, what about childhood exotropia eyes turning outward?
Intermittent exotropia is actually quite common in childhood. The outward drift might only happen when the child is tired, daydreaming, or looking at distant objects.
Right.
Constant exotropia can occur early on or result from an intermittent one decompensating over time. Yeah. There's also sensory exotropia.
What's that?
That happens when one eye has very poor vision for some reason. The lack of good visual input disrupts the brain's ability to fuse the images, and the poorly seeing eye often drifts outward.
Ah, because fusion isn't holding it in place.
Exactly. And finally, consecutive exotropia can sometimes occur after surgery to correct an esotropia, if the surgery results in an overcorrection.
Okay, so understanding these childhood patterns helps provide context if an adult presents with diplopia. Now let's move to tables 8.2 and 8.3, which list the many potential etiologies or causes of acquired horizontal and vertical diplopia, respectively. These tables look quite extensive. How are they organized?
They're generally organized by the location or type of the underlying problem. For instance, table 8.2, covering horizontal diplopia, esotropia, exotropia, groups causes into categories like disorders of cranial nerves, specifically 3 and 6 here,
Right.
Central disorders affecting brain pathways, like issues with fusion control, INO, convergence problems, that hemifield slide we discussed, disorders of the muscle itself or the neuromuscular junction, like orbital myositis, thyroid eye disease, myasthenia gravis.
Right.
And then other categories covering things like sensory exotropia or issues secondary to trauma or surgery.
Because that seems like a logical way to break it down. And table 8.3 for vertical diplopia follows a similar structure.
Yes, very similar. It includes categories for disorders of the relevant cranial nerves. 3 and 4V for vertical movement.
Right. Oculomotor and trochlear.
Neuromuscular junction disorders, again highlighting myasthenia gravis. Disorders of the muscles, like orbital floor fractures, trapping a muscle, inflammation, tumors, congenital issues.
Okay.
And specific syndromes like fallen or rising eye syndromes. It provides a really comprehensive differential diagnosis list for both horizontal and vertical acquired double vision.
Looking at these tables, myasthenia gravis appears under both horizontal and vertical causes, and also under neuromuscular junction disorders. It seems like quite the mimic.
It absolutely is. Myasthenia gravis is notorious for its ability to mimic various ocular motor palsies because it can affect any or all of the extraocular muscles, often asymmetrically and variably.
What's the hallmark feature of myasthenia affecting eye movements?
The characteristic fatigability. Diplopia or ptosis, eyelid drooping, often gets worse with prolonged use of the eyes, like sustained reading or driving, or even just holding a particular gaze for a while.
So the deviation might increase if you ask them to keep looking in one direction.
Exactly. You might see the misalignment worsen or the eyelid droop further. Lid involvement is comatosis, which can fluctuate, sometimes a variable squint, and Kogan's lid twitch sign.
What's that?
That's a brief upward twitch of the upper eyelid when the patient quickly looks down and then back to the primary position. It's quite suggestive of myasthenia.
Interesting. Any other lid signs?
Sometimes, fatigue of the orbicularis oculi muscle, the one that closes the eye, can lead to the patient sort of peeking through a partially open eyelid fissure because they can't fully close their eyes tightly or sustain closure.
Wow. And what specific conditions can myasthenia mimic, according to the text?
It's a long list. It can look like a pupil-sparing third nerve palsy, a superior division third nerve palsy, isolated abducens or trochlear palsies, an internuclear ophthalmoplegia, I know, a gaze palsy, a 1.5 syndrome, even complete external ophthalmoplegia where all eye movements are affected. It can really mimic lesions almost anywhere in the ocular motor system.
So it should always be on the differential diagnosis list for unexplained diplopia or ptosis. Are there other conditions that can mimic myasthenia's effects?
Yes, the text mentions that certain intracranial mass lesions, particularly things like paracellular tumors near the pituitary gland, aneurysms, or midbrain gliomas, can sometimes present with lid drooping or muscle weakness that might initially resemble myasthenia.
So imaging is crucial.
Absolutely. There's an example cited of intermittent unilateral ptosis being the first sign of a posterior carotid artery aneurysm.
That's serious. The text also lists several conditions in the differential diagnosis for chronic progressive external ophthalmoplegia, or CPEO, besides myasthenia and thyroid eye disease.
Right. CPEO is basically a slowly progressive weakening of all the eye muscles, often symmetrical. While myasthenia and thyroid problems are common causes, other, often rarer conditions need consideration.
Like what?
Things like oculopharyngeal dystrophy, Kearns-Sayre syndrome, a mitochondrial disorder, myotubular myopathy, myotonic dystrophy, and some metabolic disorders like Bassen-Kornzweig syndrome or Refsum syndrome. These often have other systemic features as well.
So a broad range of neuromuscular and metabolic conditions can manifest with progressive eye movement problems. Now, can issues within the retina itself ever cause binocular diplopia? It seems less likely than muscle or nerve problems.
It's noted as being quite rare, but yes, it can happen. The text describes something called the foveal displacement syndrome. This can be associated with conditions like subretinal neovascular membranes, abnormal blood vessels growing under the retina, often seen in age-related macular degeneration.
Okay.
This can occur before or sometimes after laser treatment for the condition. The proposed idea is that the membrane physically shifts the photoreceptor array in the fovea, the center of the retina.
So the center of vision is slightly moved in one eye.
Exactly. This creates a mismatch between where the center of vision should be and where it actually is, leading to a rivalry between the central and peripheral fusional mechanisms in the brain, which can manifest as binocular diplopia.
Fascinating. A physical shift in the retina causing double vision. Okay, before we dive into the specific cranial nerve palsies, our text includes figure 8.3, showing a sagittal view of the brainstem structures crucial for eye movement control. Should we briefly orient ourselves with that?
Yeah, that's a good idea. Figure 8.3 provides a really helpful anatomical map. It shows the locations of the nuclei for cranial nerves, third oculomotor, 3 trochlear, and 6 abducens within the midbrain and pons.
Okay, the command centers for the nerves.
Right. It also highlights other key structures involved in coordinating eye movements. You can see the periaqueductal gray, PG, the superior colliculus SC involved in saccades, the posterior commissure PC, important for upgaze, the interstitial nucleus of Canaeus IC, and the rostral interstitial nucleus of the medial longitudinal fasciculus, IMLF, both critical for vertical gaze and torsional movements.
Okay.
And of course, the medial longitudinal fasciculus, MLF itself, that crucial pathway connecting the different eye movement nuclei, especially 6 with third, for horizontal gaze coordination. It also shows structures like the mammillary bodies, MB, and inferior olive, IO, though their roles are broader than just eye movements.
So a complex network of interconnected structures, primarily in the midbrain and pons, all working together to control where our eyes point.
Exactly. And knowing the relative locations of these structures helps us understand why a lesion in a specific brainstem area can cause a particular pattern of eye movement deficits.
All right, let's use that anatomical grounding and start with lesions affecting the third cranial nerve, the oculomotor nerve. Where can things go wrong along its path?
The third nerve has a fairly long and complex course, so lesions can occur in several locations. As Table 8.8 outlined, problems can arise right at the nucleus in the midbrain, within the nerve fibers or fascicles as they travel through the brainstem.
Okay.
And in the subarachnoid space, after the nerve exits the brainstem, within the cavernous sinus, a space near the pituitary gland packed with nerves and blood vessels, as it passes through the superior orbital fissure into the eye socket, or finally, within the orbit itself.
So multiple potential points of failure. And Table 8.9 lists the typical causes or etiologies based on these locations.
Yes. Table 8.9 provides a differential diagnosis based on where the lesion is thought to be. For example, nuclear lesions in the brainstem might be due to congenital issues, vascular problems like stroke or hemorrhage, demyelination like an MS, tumors, or trauma.
And the clinical signs, the symptoms the patient has, will differ depending on exactly where along that path the third nerve is affected, right? Table 8.8 details this.
Precisely. The pattern of deficits is key to localization. For instance, a lesion right at the oculomotor nucleus in the midbrain is unique because of how the nucleus is organized.
How so?
Well, the part controlling the superior rectus muscle sends fibers that cross to the other side's nerve, and the part controlling the levator palpebrae muscle, eyelid elevation, supplies both eyelids from a single central structure.
Okay, that's complex.
It means a nuclear third nerve lesion often causes an ipsilateral, same side, third nerve palsy affecting most muscles, but with contralateral, opposite side, superior rectus weakness, and potentially complex lid signs.
What kind of lid signs?
You can get what's called the plus-minus lid syndrome. This typically involves ptosis, drooping, on the side of the main nerve palsy, the minus lid, and eyelid retraction, lid held too high, on the opposite side, the plus lid.
Wow. Drooping on one side, retracted on the other? What causes that?
It's thought to be due to a small lesion near the nucleus, affecting the ipsilateral levator fibers causing the ptosis, and also disrupting inhibitory pathways to the contralateral levator muscle, leading to its overaction and retraction. It's been seen with small midbrain strokes or tumors.
Fascinating pattern. What about lesions affecting the nerve fascicles as they travel through the midbrain, but after leaving the nucleus?
Fascicular lesions cause an ipsilateral third nerve palsy, but they often involve nearby structures too. For example, the fascicles pass near the red nucleus and the superior cerebellar peduncle. So a fascicular third nerve palsy might be accompanied by contralateral ataxia, incoordination, or tremor due to involvement of those adjacent pathways. These are known as specific midbrain syndromes like Benedict's or Claude's syndrome.
Okay, so associated neurological signs are key there. What about lesions outside the brainstem, in the subarachnoid space?
Once the nerve leaves the brainstem, it travels through the fluid-filled subarachnoid space towards the cavernous sinus. Lesions here often cause an ipsilateral third nerve palsy, and crucially, they frequently involve the pupil.
Why the pupil specifically?
Because the parasympathetic fibers that control pupil constriction travel on the outer superficial part of the nerve in this segment. They are very vulnerable to compression from things like aneurysms.
Ah, like a posterior communicating artery aneurysm.
Exactly. That's a classic cause of a painful third nerve palsy with a dilated, poorly reactive pupil. Other causes in this space include meningitis, hemorrhage, or inflammation.
Okay. And then the nerve enters the cavernous sinus. What happens if the lesion is there?
The cavernous sinus is crowded. The third nerve runs alongside the fourth, sixth, and parts of the fifth cranial nerves, V1 and V2, as well as the internal carotid artery and sympathetic nerve fibers.
So a lesion there likely affects more than just the third nerve.
Very often, yes. A cavernous sinus lesion causing a third nerve palsy might also cause weakness of the fourth and sixth nerves, affecting other eye movements, numbness in the forehead, V1, and potentially a Horner syndrome due to sympathetic involvement.
The Horner syndrome, that's the small pupil and echosis, right?
Correct. Meiosis, ptosis, and sometimes decreased sweating.
And after the cavernous sinus?
The nerve passes through the superior orbital fissure into the orbit. Lictions here cause similar patterns to cavernous sinus lesions, often involving multiple eye movement nerves, but they typically spare the sympathetic fibers, so Horner syndrome is less likely.
Okay. And finally, lesions within the orbit itself.
Orbital lesions can cause isolated or combined third nerve problems, but they often come with other orbital signs like proptosis, bulging of the eye, swelling, or direct involvement of the muscles themselves from inflammation or tumors within the orbit.
That detailed localization based on associated signs is really powerful. Table 8.9 lists the many possible causes for each location. We mentioned aneurysms, stroke, tumors. What else is common?
For the brainstem, demyelination, MS, is important. In the subarachnoid space, besides aneurysms and meningitis, things like uncal herniation, brain tissue pressing on the nerve, inflammatory conditions like sarcoidosis or nerve infarction due to diabetes or giant cell arteritis are key causes.
Nerve infarction, like a mini stroke affecting just the nerve.
Exactly. Often seen in diabetes, typically causing a pupil-sparing third nerve palsy because the core fibers supplying the muscles are affected by ischemia, while the superficial pupillary fibers are spared.
Ah, okay. And in the cavernous sinus?
Besides aneurysms, you think about carotid cavernous fistulas, thrombosis, clots, infections spreading from sinuses, inflammation like Tolosa-Hunt syndrome, tumors, primary or metastatic, or pituitary apoplexy.
A lot can go wrong in that small space. What about orbital causes?
Infections, inflammation like orbital pseudotumor, tumors, trauma, mucocilious expanding from sinuses.
And the table also lists causes where the localization might be unknown or systemic.
Yes, things like congenital palsies, ophthalmoplegic migraine, trauma, viral infections like herpes zoster, systemic neuropathies like Fisher syndrome or CIDP, Wernicke's encephalopathy, thiamine deficiency, and even toxic effects from drugs.
So, a huge range of possibilities. The text also describes a peculiar condition, oculomotor paresis with cyclic spasms. What is that?
It's quite rare. It involves cyclic, involuntary movements interrupting the signs of a third nerve palsy.
How does it look?
The eye might be down and out with ptosis and a dilated pupil, the paresis phase. But then every 10-30 seconds, the eyelid jerks up, the eye adducts moves inward, and the pupil constricts, sometimes with increased accommodation. Then it relaxes back into the paretic state.
Wow, like it's switching on and off. What causes it?
It's usually congenital, but it has been seen with brainstem gliomas. Acquired cases have also been linked to prior skull-based radiation therapy for tumors.
Okay. And ophthalmoplegic migraine, is that just migraine with some eye muscle weakness?
Essentially, yes, but it's a specific diagnosis. It typically starts in childhood, often affecting the third nerve, though occasionally the fourth or sixth.
What are the diagnostic criteria?
You need history of typical migraine headaches, ophthalmoplegia, nerve palsy, that occurs with or shortly after the headache starts, and importantly, other causes must be excluded through neuroimaging or other tests.
How long does the palsy last?
The nerve paresis is usually maximal as the headache resolves and can last for days to weeks, often recovering completely, though sometimes partial weakness or aberrant regeneration can remain between attacks.
Aberrant regeneration? What's that?
That's when nerve fibers regrow abnormally after injury, connecting to the wrong muscles. With the third nerve, it can lead to odd movements like the eyelid lifting when the eye looks down or inward, or the pupil constricting on adduction.
Ah, okay. And imaging might show nerve enhancement during attacks.
Yes, MRI sometimes shows enhancement and swelling of the oculomotor nerve in the cistern during an ophthalmoplegic migraine attack.
The text also mentions rare causes, like third nerve palsy after dental anesthesia.
Yes, thought to be due to retrograde flow of anesthetic along nerve or vascular pathways. And another rare cause of episodic diplopia is primary aberrant regeneration with neuromyotonia of the third nerve.
Neuromyotonia, like muscle hyperactivity.
Exactly. Brief involuntary spasms of muscles innervated by the third nerve, often triggered by sustained gaze in a particular direction. It can occur alongside signs of aberrant regeneration from a previous, often subtle injury.
Okay, that covers a lot on the third nerve. Let's move to the fourth cranial nerve, the trochlear nerve. What's unique about this one?
The trochlear nerve is anatomically unique in several ways. It's the smallest cranial nerve in terms of axon count. It has the longest intracranial course. And crucially, it's the only cranial nerve that exits from the dorsal backside of the brainstem.
Okay, and what else is special about its path?
It also decussates completely within the midbrain, meaning the nucleus on the right side controls the left superior oblique muscle, and vice versa.
Ah, so a lesion in the right trochlear nucleus affects the left eye.
Correct. Yeah. After exiting dorsally, it wraps around the brainstem, passes between the posterior cerebral and superior cerebellar arteries, a potential compression spot, pierces the dura near the edge of the tentorium, runs in the lateral wall of the cavernous sinus, below third, above V1, enters the orbit via the superior orbital fissure, and innervates just one muscle, the superior oblique. Figure 8.7 shows this path nicely.
Just one muscle, the superior oblique. What does that muscle do again?
Its primary action is intorsion, rotating the top of the eye toward the nose, and depression, moving the eye down, especially when the eye is adducted, looking inward towards the nose.
Okay, Table 8.0 summarizes the clinical features, and Table 8.11 lists etiologies by location. What are the typical symptoms of a trochlear nerve palsy?
Patients usually complain of vertical diplopia, seeing one image higher than the other, or sometimes diagonally displaced. This diplopia is typically worse on down gaze, so they have trouble reading or going downstairs. It also tends to worsen when looking towards the side opposite the weak muscle. So looking right worsens diplopia from a left superior oblique palsy.
Okay. And what about that characteristic head tilt?
Yes. Patients often adopt a compensatory head tilt away from the side of the affected superior oblique muscle to minimize the double vision. So a left superior oblique palsy often leads to a right head tilt.
And the Bielschowsky head tilt test we discussed earlier would be positive, right?
Correct. Tilting the head towards the side of the palsy makes the vertical diplopia worse.
Do patients notice the torsional component, the eye rotation?
Often they don't complain specifically about subjective cyclotropia, things looking tilted, but objectively you can usually measure some excyclotorsion, outward rotation of the affected eye, and clinically you'll see limited depression of the eye when it's attempting to look down and adduct it.
Okay. What are the common causes of fourth nerve palsies based on location? Table 8.01.
In the midbrain, nucleus fasciculus, causes are similar to the third nerve. Stroke, hemorrhage, tumor, demyelination, congenital aplasia, trauma. Because it decussates, a nuclear lesion causes contralateral palsy, while a fascicular lesion after the decussation causes ipsilateral palsy.
Right. And in the subarachnoid space?
Trauma is a big one here. Because of its long, thin course, the fourth nerve is particularly vulnerable to closed head injury, often causing bilateral palsies. Aneurysms are less common than with the third nerve. Hydrocephalus or infections can also affect it here.
Cavernous sinus and superior orbital fissure.
Same culprits as for the third nerve in those locations: tumors, inflammation, aneurysms, fistulas, infections.
And peripheral nerve issues.
Idiopathic, meaning we don't find a specific cause after investigation, is actually the most common diagnosis for isolated fourth nerve palsy. Yes. Other peripheral causes include microvascular ischemia, like in diabetes or hypertension, giant cell arteritis, Guillain-Barré syndrome, infections like herpes zoster or Lyme disease, MS, or sometimes neck trauma. Congenital fourth nerve palsy is also relatively common, though it might not become symptomatic until adulthood.
So trauma and idiopathic are leading causes, especially for isolated palsies. Now, the text mentions superior oblique myokymia. What's that? Not a palsy, right?
Correct. It's not a palsy or weakness. It's an intermittent, high-frequency, low-amplitude contraction or twitching of the superior oblique muscle.
What does the patient experience?
They usually describe brief episodes of uniocular vertical or torsional oscillopsia, like the world is shimmering or bouncing vertically in one eye, or sometimes transient double vision.
Is it serious?
It's usually benign and self-limiting, though it can be annoying. It sometimes follows a prior superior oblique palsy. It can occur spontaneously or be triggered by specific eye movements. Rarely, it can be a sign of brainstem disease like a tectoglioma or MS, but usually it's isolated and idiopathic.
Any treat.
Sometimes, medications like carbamazepine or gabapentin can help suppress the episodes.
Okay, let's move on to the final nerve controlling eye muscles. The sixth cranial nerve, the abducens nerve. What's its job and path?
The abducens nerve has one job: innervate the lateral rectus muscle, which abducts the eye, moving it outward away from the nose.
Okay, and its path?
Its nucleus is located in the lower pons, very close to the facial nerve, Sientus 7 fascicle. The nerve then takes a very long intracranial course, traveling up the brainstem surface, angling over the sharp petrous ridge of the temporal bone.
A vulnerable spot.
Definitely. It then passes through a tight spot called Dorello's Canal, enters the cavernous sinus running close to the internal carotid artery, goes through the superior orbital fissure, and into the orbit to reach the lateral rectus.
Another long journey. Table 8.12 describes clinical signs by lesion location, and 8.13 lists etiologies. What are the main clinical features of an abducens nerve palsy?
The primary symptom is horizontal diplopia, with the two images seen side by side. This diplopia is typically worse when looking at distant objects, and it increases significantly on gaze towards the side of the paretic lateral rectus muscle.
Makes sense. And objectively?
You'll see limitation of abduction. The affected eye won't be able to move fully outward. In more severe cases, the eye might even be turned slightly inward, esotropia, in the primary straight-ahead position due to the unopposed action of the medial rectus muscle.
Okay. How do the signs change depending on where the lesion is? Table 8.12. What if the lesion is at the nucleus in the pons?
A lesion destroying the abducens nucleus is different from a nerve lesion. The nucleus contains not only the motor neurons for the ipsilateral lateral rectus, but also interneurons that project via the MLF to the contralateral third nerve nucleus, specifically to the medial rectus subnucleus.
So it controls more than just the one muscle.
It controls the coordinated horizontal gaze to that side. A lesion of the abducens nucleus causes an ipsilateral horizontal gaze, palsy, inability to look towards the side of the lesion with either eye. And because the facial nerve fibers loop around the nucleus, you often get an associated ipsilateral facial weakness too.
So a gaze palsy plus facial weakness points to the pons at the nucleus level, What about a lesion of the fascicle after it leaves the nucleus but is still in the pons?
That causes just an ipsilateral sixth nerve palsy, limited abduction in that eye only.
Right.
But again, often with ipsilateral facial weakness because the sixth and seventh nerve fascicles travel close together initially. It doesn't cause a full gaze palsy.
Okay, nerve palsy plus facial weakness points to the fascicle in the pons. What about lesions outside the brainstem in the subarachnoid space?
Due to its long course, the sixth nerve is vulnerable here. It can be affected by meningitis, tumors, increased intracranial pressure, which can stretch the nerve as the brainstem shifts downward, a false localizing sign, or vascular compression. Isolated sixth nerve palsy is common from lesions here.
And in the cavernous sinus?
Similar to the third and fourth nerves, lesions here often involve multiple cranial nerves, 3-4 V1 sags, and potentially Horner syndrome.
Superior orbital fissure and orbit.
Again, similar patterns involving multiple nerves, possibly with ptosis or other orbital signs depending on the exact location and cause, tumor, inflammation, trauma.
Okay, Table 8.13 lists the many etiologies. What are some key causes for each location? Nuclear lesions.
Pontine stroke or hemorrhage, tumors, demyelination, MS, Wernicke-Korsakoff syndrome, congenital conditions like Mobius syndrome,
Vesicular.
similar vascular demyelinating neoplastic causes, plus things like perineoplastic syndromes, anti-U.
Subarachnoid space. This seems like a high-risk area.
Yes. Meningitis, infectious or carcinomatous, aneurysms, less common than for CN3, neurovascular compression causing recurrent palsies, complications after procedures like lumbar puncture due to traction, inflammatory conditions like sarcoidosis, infections like Lyme or TB, skull-based tumors like chordomas, acoustic neuromas, increased intracranial pressure from any cause.
Wow, lots of possibilities. Cavernous sinus orbit.
Same broad categories. Vascular, aneurysm, fistula, thrombosis, infectious, inflammatory, Tolosa Hunt, neoplastic, primary or metastatic, trauma.
And peripheral nerve causes for isolated sixth nerve palsy.
Again, idiopathic is very common in adults, especially older adults. Microvascular ischemia due to diabetes or hypertension is another major cause. Giant cell arteritis must be considered in the elderly. Increased intracranial pressure is also a key cause of often bilateral sixth nerve palsies.
The text also mentions congenital cranial dyssynervation disorders linked to gene mutations.
Yes, these are developmental conditions where nerves don't wire up correctly. Examples include Duane syndrome, often involves limited abduction and sometimes abnormal lid movements, horizontal gaze palsy with scoliosis, or congenital fibrosis of the extraocular muscles, CFE-ANO. These present in childhood typically.
Okay. And briefly, Miller-Fisher syndrome. It's mentioned here too.
Right. Miller-Fisher syndrome is considered a variant of Guillain-Barré syndrome. The classic triad is ophthalmoplegia, eye muscle weakness, ataxia, incoordination, and orthorexia, loss of reflexes.
How does the eye involvement usually start?
Often with diplopia, frequently due to unilateral or asymmetric sixth nerve palsy initially, but it can rapidly progress to affect multiple eye muscles, often leading to bilateral, fairly complete external ophthalmoplegia within days. Ptosis is common, but pupillary involvement is unusual.
And it's associated with specific antibodies.
Yes. Anti-GQ1b IgG antibodies are often found, especially in cases with ophthalmoplegia. It can sometimes relapse or occur as part of CIDP, chronic inflammatory demyelinating polyneuropathy.
Okay, that covers the individual cranial nerves involved in eye movements. Now let's turn our attention to the pupils and the pathways that control them. How does the pupillary light reflex work?
It's a reflex arc. Light hits the retina, signals travel via the optic nerve, CN2, to the protectal nuclei in the midbrain. These nuclei then project bilaterally to the Edinger-Westphal nuclei, which are part of the oculomotor nerve CN3 complex.
Bilaterally, so light in one eye affects both pupils.
Exactly. That's why we have both a direct response, pupil constricts in the eye where light is shown, and a consensual response, the other pupil also constricts. From the Edinger-Westphal nuclei, parasympathetic fibers travel with the third nerve to the ciliary ganglion in the orbit, and then postganglionic fibers go to the iris sphincter muscle, causing constriction, miosis.
Got it. That's the parasympathetic pathway for constriction. What about the pathway for dilation?
That's the sympathetic pathway. It's a longer 3-neuron chain. It starts in the hypothalamus, descends through the brainstem into the spinal cord to about the T1 level.
Okay, first neuron.
Right. The second neuron goes from the spinal cord up the neck in the sympathetic chain to the superior cervical ganglion.
Second neuron.
And the third neuron travels from the ganglion along the internal carotid artery, enters the skull, joins the ophthalmic division of the trigeminal nerve, V1, and finally reaches the iris dilator muscle, causing dilation, mydriasis.
A much longer and more circuitous route. Now, a key sign related to pupils is anisocoria, unequal pupil sizes. How does anisocoria help localize problems?
Anisocoria is a very important clue. The first thing you check is the pupillary light reaction in both eyes.
Okay.
If the light reaction is poor in the larger pupil, and assuming vision, the afferent pathway via CNT, is normal, you suspect a problem with the parasympathetic pathway, usually involving the third nerve somewhere along its course. Think compression or damage. Figure 8.1 illustrates this well.
Okay. Large pupil plus poor reaction, parasympathetic problem, likely CN3. What if the smaller pupil is the abnormal one?
If the anisocoria becomes more noticeable in dim light because the normal pupil dilates well in the dark while the smaller one doesn't, you suspect a sympathetic pathway defect. That's Horner syndrome.
Ah, okay. Worse in dim light points to Horner's sympathetic failure.
Conversely, if the anisocoria is more prominent in bright light and lessens in dim light, it supports a parasympathetic lesion because the abnormal larger pupil fails to constrict properly to light.
Got it. And ptosis, the droopy eyelid, can occur with either pathway lesion.
Yes, but the characteristics differ. Ptosis with a third nerve palsy is often quite severe, potentially covering the pupil. Ptosis with Horner syndrome is usually milder, maybe only 1 to 2 millimeters, due to weakness of Miller's muscle in the eyelid, which has sympathetic innervation.
Okay. What if the anisocoria is present, but the light reaction seems normal in both eyes?
Then you need to consider a few possibilities. It could be physiologic anisocoria, a small, stable difference in pupil size that's present in about 20% of the population and is harmless.
Okay.
It could still be a subtle Horner syndrome, especially if the difference is more apparent in dim light. Or, less commonly, it could be sympathetic irritation causing transient dilation of one pupil.
Right. Now, you mentioned the pupillary fibers travel with the third nerve. Where exactly are they located within the nerve bundle?
This is clinically very important. The parasympathetic pupillomotor fibers are located peripherally, right under the nerve sheath, epineurium, especially on the superior and medial aspect of the nerve as it runs through the subarachnoid space. Figures 8.1 and 7.4 illustrate this.
And why is that location significant?
Because it makes them particularly vulnerable to external compression, for example, from an expanding aneurysm or uncal herniation. These often affect the pupil early. In contrast, ischemic damage, like from diabetes, tends to affect the core of the nerve first, often sparing the peripheral pupillary fibers, leading to a pupil-sparing third nerve palsy.
That explains the pupil-sparing versus pupil-involving distinction. Let's talk more about Horner syndrome. You mentioned the triad, miosis, myotosis. What was the third part?
Anhidrosis, which is decreased sweating on the affected side of the face or body. So small pupil, mild ptosis, and potentially anhidrosis, all due to disruption of that sympathetic pathway.
Can the location of the disruption along that 3-neuron path be determined?
Sometimes. Lesions affecting the second-order neuron, preganglionic, running from the spinal cord up to the superior cervical ganglion of the neck, can sometimes cause neck or arm pain. Causes are listed in Table 8.15, things like Pancoast tumors at the lung apex, neck trauma or surgery, or spinal cord lesions. Okay.
And postganglionic lesions affecting the third-order neuron after the ganglion.
These often present with ipsilateral facial pain, sometimes resembling cluster headaches with tearing, flushing, or nasal congestion. Importantly, anhidrosis is often absent with postganglionic lesions, or limited just to the forehead because the sweat fibers for most of the face branch off before or at the ganglion. Table 8.16 lists causes here.
What are some key causes of postganglionic Horners?
A Horner syndrome presenting with retroorbital pain should raise concern for a cavernous sinus pathology, sometimes called Rader's paratrigeminal neuralgia. Other third-order causes include infections or inflammation near the pathway, like otitis, sinusitis, lymph node issues, tumors, trauma like basilar skull fractures, vascular issues.
Vascular issues like what?
A really important one is carotid artery dissection or occlusion. A painful Horner syndrome, especially if acute, should prompt urgent investigation for carotid dissection. It's a common presentation.
Okay, painful Horners, a suspect carotid dissection. Got it. Can Horners alternate sides?
Rarely, yes. Alternating Horner syndrome over days or weeks has been described with central lesions like cervical spinal cord problems, syringomyelia, radiation damage, or autonomic failure syndromes like Shy-Drager. Recurrent isolated Horners can also occur.
Okay, that covers pupil constriction issues like Horners. What about causes of pupillary dilation or mydriasis?
Well, the most common cause is probably pharmacologic, accidental, or intentional exposure to drops or substances that block the parasympathetic system, like atropine, scopolamine, even certain plants. These pupils will be widely dilated and completely unreactive to light.
Right, eye drops. What about neurological causes of a dilated pupil?
A tonic pupil, often called an 80s pupil, is a key one. Here, the pupil is dilated and reacts very poorly, if at all, to light. You might see segmental palsy of the iris sphincter under magnification. A key feature is light-near dissociation. The pupil reacts minimally to light, but it does constrict slowly and tonically during accommodation, focusing on a near object, and then relegates even more slowly when looking back at distance.
Light-near dissociation. What causes a tonic pupil?
It's thought to be due to damage to the ciliary ganglion, or the short ciliary nerves in the orbit, often followed by aberrant regeneration. Table 8.18 lists many causes: local orbital lesions, infections like syphilis, zoster, inflammation, ischemia, tumors, trauma, even sometimes after local anesthesia or laser procedures.
And 80 syndrome, is that just a tonic pupil?
80 syndrome, or Holmes-80 syndrome, specifically refers to a tonic pupil, often unilateral initially, more common in young women, associated with absent or diminished deep tendon reflexes, particularly ankle and knee jerks. Corneal sensation might also be impaired. Over years, the pupil often becomes small and myotic, little old 80s.
Interesting. Are there other syndromes with tonic pupils?
Yes. Ross syndrome involves a tonic pupil with hyporeflexia and progressive segmental loss of sweating, hypohidrosis. Also, bilateral tonic pupils should always prompt testing for syphilis, as it can be a manifestation of taboparesis.
Okay. Besides pharmacologic causes, and tonic pupils can direct damage to the iris cause dilation.
Yes, iris damage from ischemia, trauma, or severe inflammation, uveitis, can lead to a dilated or irregularly shaped pupil that doesn't react well. Usually there's no associated ptosis or eye movement problem, and you might see tears in the sphincter muscle on slit lamp exam. These pupils typically don't constrict well, even with strong myotic drops like pilocarpine.
Can dilation be transient?
Transient unilateral mydriasis is rare, but has been reported, sometimes associated with migraine or even carotid dissection.
Okay, now, briefly, what about pupillary constriction, or miosis, besides Horner syndrome?
Again, pharmacologic causes are common using myotic eye drops, like pilocarpine for glaucoma, or systemic exposure to parasympatomimetic agents.
Right. What about extreme miosis, pinpoint pupils?
Bilateral pinpoint pupils are a classic sign of pontine hemorrhage, stroke in the pons disrupting descending sympathetic pathways, or narcotic overdoses, like opioids. Certain metabolic encephalopathies can also cause small but reactive pupils.
And unilateral extreme miosis.
Usually suggest accidental installation of a strong myotic eye drop in just that one eye.
Okay. Table 8.19 summarizes key pupillary signs in the ICU setting. Can you quickly recap those? They seem very important.
Sure. A unilateral, large, poorly reactive pupil often suggests a compressed third nerve, for example, from brain herniation, direct eye trauma, or accidental anticholinergic exposure, like from nebulizers.
Critical sign. What about bilateral fixed dilated pupils?
That's very ominous. Suggests severe brain anoxia, lack of oxygen, brain death, or possibly a massive anticholinergic overdose.
Okay. Bilateral small but reactive pupils.
That points towards narcotic overdose, certain metabolic encephalopathies, or a pontine lesion.
And a unilateral small reactive pupil.
That's typically a Horner syndrome.
Great summary. Those are really vital signs in critically ill patients. Now, we've covered the nerves and muscles themselves. Let's move up a level to the supranuclear control of eye movements, the brain systems that orchestrate these movements.
Right. This involves complex interactions between various brain regions above the level of the cranial nerve nuclei in the brainstem. These systems generate the precise, coordinated movements needed for clear vision and interacting with our environment.
And some of these are involuntary reflexes, right? Like the vestibulo-ocular reflex, the VOR?
Exactly. The VOR is a fundamental reflex. The vestibular system in our inner ear detects head movement and almost instantaneously triggers compensatory eye movements in the opposite direction.
They keep the image stable on the retina when our head moves.
Precisely. It's why you can, for example, read a sign while walking or jogging. Without the VOR, the visual world would appear jumpy and blurred during head movements.
We usually don't notice the VOR working, right?
Nonetheless, there's an imbalance, maybe from an inner ear problem or a brainstem lesion affecting the vestibular pathways. Then you might get vertigo or oscillopsia.
And caloric testing is a way to assess the VOR.
Yes. Caloric testing involves irrigating the external ear canal with cold or warm water. With the head tilted back 30 degrees, this primarily stimulates the horizontal semicircular canal.
Okay. What's the normal response?
Let's take cold water in the right ear. The normal response in an awake person is a slow, tonic deviation of both eyes towards the side being stimulated, so towards the right. This slow phase is the VOR component.
Okay. Eyes drift towards the cold water.
But then the cortex generates a corrective fast eye movement, a saccade, back towards the opposite side to the left. This sequence of slow drift and fast correction creates nystagmus, with the fast phase beating away from the cold stimulus.
And the mnemonic CIWS helps remember the direction of the fast phase.
Right. Cold opposite, warm same. Cold water causes nystagmus beating to the opposite side. Warm water causes nystagmus beating to the same side.
How does this change in a comatose patient?
A comatose patient with an intact brainstem will still have the slow VOR deviation towards the cold stimulus, but they typically lack the fast corrective saccade generated by the cortex. So you just see the eyes slowly drift towards the irrigated ear and stay there until the stimulus wears off. Absence of even the slow deviation implies a severe brainstem injury.
So caloric testing is a powerful brainstem function test in coma. Now, besides reflexes like the VOR, the cerebral cortex exerts voluntary control over eye movements too, doesn't it?
Absolutely. The cortex is responsible for initiating voluntary eye movements, directing visual attention, and integrating eye movements with other sensory information and goals.
Our text mentions the visual processing pathway, from the eye via the lateral geniculate nucleus, LGN, to the primary visual cortex, striate cortex. Then where?
From the primary visual cortex, information flows to areas specialized for motion processing, like area MT, which detects speed and direction, and then MST, which integrates visual motion signals with information about the eye's own movement, eye velocity.
Okay, and these areas project elsewhere.
Yes, there are connections between MT and MST in both hemispheres via the corpus callosum. In humans, homologous areas are thought to be in the lateral occipital cortex and parts of the angular gyrus region.
And from these motion processing areas?
Projections go to the posterior parietal cortex, particularly around the intraparietal sulcus, which is crucial for visual attention, spatial awareness, and planning visually guided movements, including saccades.
And then onto the frontal lobe.
Yes, these parietal areas, along with MT and MST, project heavily to the frontal eye fields, or FEF, located in Brodmann Area 8 in the frontal lobe.
What's the main job of the FEF?
The FES is primarily involved in generating intentional saccades, especially contralateral ones, to the opposite side. It plays a key role in voluntarily exploring the visual environment. Lesions here particularly impair non-visually guided intentional saccades, like looking towards a remembered location.
Is there a parietal eye field too?
Yes, the PEF is located in that intraparietal sulcus region we mentioned, areas 3, 9, 40. It projects to the FEF and also down to the superior colliculus in the midbrain. The PEF seems more involved in triggering visually guided intentional saccades.
What happens with PEF lesions?
Unilateral lesions tend to cause increased latency, slower initiation, and hypometria, undershooting of saccades, towards the contralateral side. Bilateral parietal lesions can result in a profound deficit called ocular motor apraxia, where patients have great difficulty initiating any voluntary saccades, even though reflexive eye movements might be intact.
And the supplementary eye field, SEF, where's that?
The CEF is located more medially in the frontal lobe, just superior to the FEF. It seems involved in more complex aspects, like learning sequences of saccades or generating saccades based on internal goals rather than external cues.
Okay. The text also mentions the role of the prefrontal cortex and superior colliculus in suppressing unwanted reflexive saccades.
Right. Imagine you're trying to fixate on something and suddenly something flashes in your periphery. There's a strong reflex to look towards it, mediated largely by the superior colliculus SC.
But we can consciously stop ourselves from looking.
Exactly. The dorsolateral prefrontal cortex, DLPFC, plays a key role in this inhibition. It exerts top-down control, possibly via inhibitory connections involving the basal ganglia, which tonically inhibit the SC, and maybe also through direct inhibitory pathways from the DLPFC to the SC itself, effectively canceling the reflexive saccade command. Dysfunction in this system, perhaps due to thalamic issues reducing DLPFC activation, might lead to difficulty suppressing these unwanted saccades.
So a complex interplay between cortical excitation and inhibition controlling even simple reflexes and combined lesions.
Combined lesions of the FEF and the ipsilateral superior colliculus cause a severe and permanent impairment of saccades towards the contralateral side.
That highlights the overlapping roles and robustness of the system. Let's talk more specifically about saccades themselves.
Okay. Saccades are those rapid, conjugate eye movements we use to shift our gaze abruptly from one point of interest to another.
And there are different types.
Broadly, yes. We can think of reflexive saccades, triggered automatically by an external stimulus, like that flash in the periphery or a sudden sound.
Okay.
And then intentional saccades, which are voluntary and internally generated. These include visually guided saccades, looking deliberately at a target, predictive saccades, anticipating where a target will appear, and memory-guided saccades, looking back to where something was previously seen.
When we make a saccade, the world doesn't seem to blur or jump, even though our eyes are moving incredibly fast. Why is that?
That's due to mechanisms like saccadic suppression and visual masking. Essentially, visual sensitivity is actively reduced during the saccade itself.
How does that work?
It's thought to involve central inhibitory processes, reduce neural activity in pathways, including the superior colliculus, LGN, and even primary visual cortex during the eye movement itself. This prevents the perception of a smeared image.
Fascinating. And saccades require alertness.
Yes. You need to be reasonably alert to generate normal saccades, especially the voluntary ones. As we mentioned, comatose patients lose the fast corrective saccades seen in caloric testing or optokinetic nystagmus.
How are saccades generated mechanically? What makes the eye move so fast and then stop accurately?
It involves a precise combination of signals. There's a high-frequency burst of neuronal activity, the pulse that provides the velocity command to rapidly overcome orbital viscosity and move the eye.
Okay, the pulse gets it moving fast.
Then, there's a change in the baseline tonic innervation level, the step which holds the eye steady in its new position against elastic restoring forces in the orbit. There's a transition phase too, sometimes called a slide, bridging the pulse and step. It's often described as a pulse step or pulse slide step mechanism.
And the speed of saccades varies.
Yes, there's a characteristic relationship between saccade amplitude, how far the eye moves, and its peak velocity. Larger saccades are faster, following a main sequence. Peak velocities can range from around 100 degrees per second for small saccades, up to 700 degrees per second or more for large ones.
What factors affect saccade velocity?
Age is one. Saccades tend to get slower as we get older. Alertness is key. Drowsiness, inattention, or sedative medications slow them down. Target predictability can actually increase velocity slightly. Latency, the time it takes to initiate a saccade after a signal, is typically around 200 milliseconds.
How does the brain calculate the right pulse and step signals to land accurately on target?
It's complex, involving internal representations of target location, sensory maps, and current eye position, using proprioceptive feedback or copies of motor commands. Neural circuits essentially compare the desired eye position with the actual eye position to compute the necessary pulse and step signals.
And errors in these mechanisms lead to abnormal saccades.
Exactly. Problems can result in abnormally slow saccades, inaccurate amplitude, dysmetria overshooting or undershooting the target, or an inability to maintain stable fixation after the saccade.
Where in the brainstem are the neurons that generate the immediate saccade commands?
These are the burst neurons. For horizontal saccades, the excitatory burst neurons, EBNs, are located in the pontine paramedian reticular formation, or PPRF, near the abducens nucleus. Inhibitory burst neurons, IBNs, which silence antagonist muscles during the saccade, are nearby and also in the medulla.
Okay, PPRF for horizontal bursts. What about vertical and torsional saccades?
The burst neurons for vertical and torsional movements are located higher up in the midbrain, specifically within the rostral interstitial nucleus of the medial longitudinal fasciculus, MLF, and adjacent areas. EBNs and IBNs are intermingled here. Each RMLF seems to primarily control bursts for saccades and quick phases in one direction. For example, upward and torsional or downward and torsional.
So specific midbrain centers for vertical torsional bursts. And what part of the brain ensures saccades are accurate, preventing dysmetria?
The cerebellum plays a critical role here, particularly the midline structures, the dorsal vermis, and the underlying fastigial nuclei. These areas receive information about the planned saccade and ongoing eye movement, and provide corrective signals to the brainstem burst generators to ensure the saccade lands accurately on target. Lesions here classically cause saccadic dysmetria.
So the cerebellum fine-tunes saccadic accuracy. Let's talk a bit more broadly about the cerebellum's influence on eye movements.
The cerebellum is absolutely crucial for coordinating and calibrating almost all types of eye movements, not just saccades. It's essential for smooth pursuit eye movements, tracking moving objects, adaptation of the VOR, maintaining gaze stability, and ensuring appropriate gain and timing of movements.
And specific vascular syndromes affecting the cerebellum can cause characteristic eye signs. Our text refers to Chapter 16 for details, but can you give an example?
Sure. An infarction in the territory of the anterior inferior cerebellar artery, AICA, often causes vertigo, vomiting, hearing loss, and facial weakness. Ocular findings might include gaze-evoked nystagmus appearing when looking eccentrically, impaired smooth pursuit, and signs of unilateral vestibular loss on head impulse, testing the eye's lag behind when the head is turned quickly towards the lesion side, requiring catch-up saccades.
Okay. And a large cerebellar stroke or hemorrhage.
If it causes swelling and compresses the adjacent brainstem, you can see a variety of acute eye movement disorders. Horizontal or vertical gaze limitations, various types of nystagmus, skew deviation, vertical misalignment, ocular bobbing, a specific abnormal movement, and potentially palsies of cranial nerves the third to sixth due to direct brainstem compression.
So cerebellar lesions can cause a wide array of eye signs, both directly and indirectly via brainstem effects. Let's return to abnormal saccades specifically. How are they assessed clinically?
At the bedside, you typically test saccades by having the patient look back and forth rapidly between two fixed targets, like your finger and your nose. You observe the latency, initiation speed, trajectory, is it straight or curved? Accuracy, do they overshoot or undershoot? Velocity, do they seem slow? And conjugacy, do both eyes move together?
Okay.
Using an optokinetic drum or tape, which has repeating stripes, is also a good way to elicit and observe quick phases, which are essentially reflexive saccades.
And lesions in those saccade-generating pathways we discussed lead to specific abnormalities.
Yes. Problems can result in saccades that are initiated inappropriately, are inaccurate dysmetric, are abnormally slow, or are completely absent in certain directions.
We mentioned saccadic dysmetria, overshooting, hypermetria, or undershooting, hypometria. That often indicates cerebellar dysfunction, right?
Correct, especially involving the vermis or fastigial nucleus. It's a hallmark of cerebellar eye signs.
What about abnormally slow saccades?
Slow saccades can be seen in a wide variety of conditions. Brainstem disorders affecting the burst neurons, like pontine lesions slowing horizontal saccades, or midbrain lesions slowing vertical ones. Certain neurodegenerative diseases, like progressive supranuclear palsy, PSP, which classically slows vertical saccades first. Neuromuscular junction disorders, like myasthenia, where saccades fatigue and slow. Metabolic problems or drug effects. Sedatives, anticonvulsants. Sometimes horizontal saccades might be selectively slowed more than vertical ones, or vice versa, providing localization clues.
Okay. And what are ocular flutter and opsoclonus?
These are involuntary, rapid, back-to-back saccadic oscillations without any pause in between, no intersaccadic interval. They essentially pull the eyes off target. Ocular flutter consists of bursts of these oscillations purely in the horizontal plane.
Okay.
Opsoclonus is more dramatic. The saccadic oscillations are multidirectional, horizontal, vertical, and torsional, often appearing chaotic or dancing.
What causes flutter and opsoclonus?
They are often associated with dysfunction in the brainstem or cerebellum, particularly involving pathways related to saccade control and gaze holding. Opsoclonus, especially in children, can be a paraneoplastic phenomenon associated with neuroblastoma. In adults, it can be paraneoplastic, for example, with lung or breast cancer, or related to infections, toxins, or metabolic issues. They indicate instability in the saccadic system.
And square wave jerks, are those related?
Square wave jerks are different. They are small, inappropriate saccades that involuntarily move the eyes off the fixation target, followed shortly by a corrective saccade back to the target. There's a brief pause on the eccentric position, unlike flutter opsoclonus.
Are they always abnormal?
Small, infrequent square wave jerks can be seen in normal individuals, especially when tired or elderly. However, frequent or large ones are often associated with neurological conditions, particularly cerebellar degeneration or progressive supranuclear palsy, PSP.
Okay, that covers saccadic abnormalities well. Let's move to convergence and divergence issues. First, convergence.
Convergence is the process where both eyes turn inward simultaneously, mediated by the medial rectus muscles, innervated by CN3, to maintain single binocular vision when looking at a near object.
And this is controlled supranuclearly.
Yes, the initiation and control involves cortical areas, likely including the frontal eye fields, projecting down to midbrain centers that coordinate the activity of both medial recti and also link it with accommodation, focusing, and pupillary constriction, the near triad.
What happens in convergence insufficiency?
Convergence insufficiency is a common condition, especially noted in students doing a lot of near work, but also seen in the elderly or after mild head trauma. It can also occur with acquired cerebral lesions.
What are the symptoms?
Patients complain of eye strain, headaches, blurred vision, letters seeming to run together or move after sustained reading, and sometimes frank double vision, specifically at near. Closing one eye often brings relief.
And the signs on examination?
You'll typically find an exodeviation, tendency for eyes to drift out, that is greater when looking at near targets compared to distant targets. Adduction, individual eye movement inward, is usually normal, but the near point of convergence, the closest point they can hold fusion before one eye drifts out, is remote, farther away than expected.
Is convergence affected in specific neurological diseases?
Yes, impaired or absent convergence is commonly seen in Parkinson's disease, and especially in progressive supranuclear palsy, PSP.
Okay. What about the opposite convergence spasm?
Convergence spasm is a sudden, involuntary, sustained, excessive convergence of both eyes. It's often accompanied by excessive accommodation, leading to blurred distance vision and pupillary constriction, myosis.
What causes that?
It can sometimes be functional or psychogenic, but it can also be associated with neurological conditions affecting the midbrain, such as Perronneau syndrome, dorsal midbrain syndrome, or occur after head injury.
Okay, now what about divergence, the opposite of convergence?
Divergence refers to the simultaneous outward movement of both eyes, mediated by the lateral rectus muscles, CNVI, typically when shifting gaze from a near object to a far one. The supranuclear control mechanisms for divergence are less well understood than for convergence.
Can divergence be insufficient?
Yes, divergence insufficiency presents as an esotropia, inward turning, that is significantly greater when looking at distant targets compared to near targets. It can sometimes be a benign age-related finding, but it can also be a sign of underlying neurological disease, particularly conditions causing increased intracranial pressure or lesions in the pons near the abducens nuclei.
And divergence paralysis?
Divergence paralysis is a more complete inability to actively diverge the eyes. Patients complain of sudden onset horizontal diplopia, crossed images, meaning the image seen by the right eye is to the left, primarily at distance. It's often associated with underlying neurological conditions like brainstem lesions, especially pons, head trauma, or Wernicke's encephalopathy.
So problems with convergence and divergence relate mostly to near versus distance viewing and can have various neurological causes. Now, let's talk about gaze palsies. What defines a gaze palsy?
A gaze palsy, or gaze paresis, is an inability to move both eyes conjugately together in a particular direction. This typically indicates a lesion above the level of the individual cranial nerve nuclei, supranuclear, or at the level of a nucleus that coordinates gaze, like the abducens nucleus for horizontal gaze.
Okay. Let's start with horizontal gaze palsy, inability to look left or right. Where could the lesion be?
A unilateral lesion in the pons affecting the PPRF, paramedian pontine reticular formation, the brainstem center for horizontal saccades and gaze, will cause an ipsilateral horizontal gaze palsy. The patient cannot generate saccades or pursue targets towards the side of the lesion. However, the vestibulo-ocular reflex, VOR, might still be intact initially,
Rename.
meaning if you turn the patient's head passively, doll's eye maneuver, their eyes might still move conjugately in the direction they can't voluntarily look. This is called a dissociated gaze palsy.
Okay. What if the VOR is also lost in that direction?
That suggests the lesion involves not just the PPRF, but also the nearby abducens nucleus itself, which is essential for both voluntary gaze and the VOR in that direction. This causes a non-dissociated gaze palsy.
What about cortical lesions, like in the frontal eye field, FEF?
An acute large lesion in one FEF, like a stroke, can cause a transient contralateral gaze paresis. The eyes deviate towards the side of the lesion, and the patient has difficulty looking voluntarily away from the lesion. However, this cortical gaze palsy usually recovers substantially over days or weeks, and reflexive movements like the VOR are typically preserved.
Okay. And bilateral PPRF lesions?
Devastating. That results in a complete loss of all horizontal eye movements, both voluntary and reflexive. Vertical movements might be spared.
What about vertical gaze palsy, inability to look up or down?
Vertical gaze control is primarily mediated by structures in the dorsal midbrain. Supranuclear vertical gaze palsies often affect up gaze more severely than down gaze.
Is there a classic syndrome associated with this?
Yes, Perronneau syndrome, or the dorsal midbrain syndrome. It's characterized by impaired up gaze, sometimes down gaze too. Pupillary abnormalities like light near dissociation. Pupils don't react well to light but constrict on convergence. Convergence retraction nystagmus. Eyes jerk back into the sockets with attempted upgaze or convergence. And sometimes eyelid retraction. Collier's sign.
What causes Perronneau syndrome?
Common causes include pineal region tumors compressing the dorsal midbrain, hydrocephalus expanding the aqueduct, or strokes or demyelination in that area.
Are there nuclear vertical gaze palsies?
They are much rarer than supranuclear ones and would typically affect specific muscles or movements depending on which parts of the third or fourth nerve nuclei in the midbrain were involved.
Okay. Now, a really important condition related to gaze coordination is internuclear ophthalmoplegia, or ANO. What is that?
INO is caused by a lesion affecting the medial longitudinal fasciculus, the MLF. Remember, that's the pathway connecting the abducens nucleus, CNC, in the pons, with the contralateral oculomotor nucleus, CNSA, in the midbrain, specifically the part controlling the medial rectus muscle.
Right, the pathway for coordinating horizontal gaze.
Exactly. The hallmark of an INO is impaired adduction, inward movement, of the eye on the same side as the MLF lesion during attempted horizontal gaze.
So if the left MLF is damaged, the left eye won't adduct well when looking to the right.
Correct. And classically, there's also horizontal nystagmus in the abducting eye, the right eye in this example when looking right.
Okay, ipsilateral adduction failure plus contralateral abducting nystagmus. Is convergence affected?
Convergence, which requires both medial recti to fire, but doesn't rely on the MLF pathway from the abducens nucleus, is often preserved in INO. This can help differentiate it from a medial rectus palsy due to a third nerve lesion.
Can INO be unilateral or bilateral?
It can be either. Bilateral INO is very common in multiple sclerosis, especially in younger patients. Unilateral INO in older patients is more often caused by a small brainstem stroke, lacunar infarct, affecting the MLF.
Are there variants? The text mentions Webino and Wemino.
Yes. Webino stands for wall-eyed bilateral INO. Patients have bilateral INO and their eyes are deviated outward, exotropic, in primary position. It's often seen in younger patients with MS or brainstem inflammation.
Okay. And Wemino?
Wall-eyed monocular INO. That's a unilateral INO accompanied by an exotropia of the ipsilateral eye.
Are there conditions that can mimic INO?
Yes, myasthenia gravis can cause a pseudo-INO due to fatigable weakness of the medial rectus. Other mimics include Guillain-Barré variants, thyroid eye disease restricting adduction, orbital pseudotumor, partial third nerve palsy, Miller-Fisher syndrome, or even surgical damage to a medial rectus. Careful examination for fatigability, ptosis, or other signs is needed.
There's also mention of an atypical INO and vitamin E deficiency.
Right, indictylipoproteinemia. It involves slowing of the abducting eye's saccades and nystagmus in the abducting eye, which is sort of the reverse of typical INO, though it can resemble Webino superficially.
Okay, that's INO. What about the 1.5 syndrome? That sounds descriptive.
It is. It describes a combination of a conjugate horizontal gaze palsy to one side, the 1, plus an internuclear ophthalmoplegia affecting adduction when looking to the other side, the 1.5.
So what's the only horizontal movement left?
The only remaining horizontal eye movement is abduction of the eye contralateral to the side of the gaze palsy, and that eye often shows nystagmus when it abducts.
Where is the lesion causing this?
It requires a lesion in the pons that damages both the PPRF or abducens nucleus on one side, causing the ipsilateral gaze palsy, the 1, and the ipsilateral MLF before it crosses, causing the failure of adduction of that eye when looking the other way, the 1/2.
Can it be dissociated or non-dissociated?
It depends on whether the lesion involves just the rostral PPRF, potentially sparing VOR, dissociated, or extends down to include the abducens nucleus, affecting VOR, non-dissociated.
Is there often an associated eye deviation in primary position?
Yes. Patients with 1.5 syndrome often have an exotropia of the contralateral eye, the one that can still abduct, sometimes called paralytic pontine exotropia. Rarely, esotropia can occur.
Are there other variations?
Variations involving ptosis, abduction paralysis, or adduction nystagmus have been described with rostral brainstem infarcts, and there's even a vertical 1.5 syndrome.
Really? What's that?
It involves paralysis of gaze in one vertical direction, say up gaze, combined with paralysis of movement in the opposite direction, down gaze, in just one eye. It's been reported with thalamomesencephalic strokes, or bilateral mesodiencephalic infarcts affecting vertical gaze pathways asymmetrically.
Wow, complex patterns pointing to very specific lesion locations. Now, what about skew deviation?
Skew deviation is a vertical misalignment of the eyes, one eye is higher than the other, that's caused by an imbalance in the otolithic vestibular inputs to the ocular motor nuclei. It's not due to weakness of a specific muscle, but rather a supranuclear imbalance, usually originating in the brainstem or cerebellum.
How is it different from a trochlear nerve palsy, which also causes vertical misalignment?
Skew deviation is often commitinent, meaning the vertical misalignment stays relatively the same in different horizontal gaze positions, whereas a trochlear palsy is typically incomitant, worse in certain gaze directions. Also, skew deviation is frequently accompanied by ocular torsion, cyclotorsion, and often a tilt of the subjective visual vertical. The patient perceives vertical lines as tilted. These features strongly suggest a disruption of the vestibular pathways.
So skew, vertical misalignment, plus often torsion, plus often commitment, plus vestibular pathway problem. Where are the lesions typically?
Lesions can be anywhere along the vestibulo-ocular pathways in the brainstem, pons, medulla, midbrain, or in the cerebellum. It's often seen as part of broader syndromes like Wallenberg syndrome, lateral medullary infarct, or with cerebellar strokes or MS plaques.
Can it be transient or alternating?
Yes, transient skew deviation can occur with stroke, MS, trauma, Chiari malformation, hydrocephalus, or even paraneoplastic syndromes. And alternating skew deviation, where the hypertropic eye changes depending on the direction of horizontal gaze, can be a particularly important sign.
How so?
Alternating skew, where both eyes look down when adducted, bilateral deducting hypertropia, especially if seen with signs of dorsal midbrain dysfunction, protectal signs, can indicate hydrocephalus or a lesion needing urgent neurosurgical attention.
Okay. And if both eyes look up when abducted?
An alternating skew with bilateral abducting hypertropia, especially if it's associated with downbeat nystagmus and ataxia, often points towards a lesion at the cervicomedullary junction or in the cerebellum.
Can skew occur in isolation or paroxysmally?
Yes, constant, transient, or even paroxysmal skew, for example with migraine, vertebrobasilar ischemia, or rarely epilepsy, has been described.
The text mentions the pattern of skew deviation, which eye is lower, can help localize along the brainstem.
Yes, there's evidence suggesting that lesions in the caudal pons or medulla tend to cause an ipsiversive skew, the eye on the same side as the lesion is lower, while lesions in the rostral pons or midbrain tend to cause a contraversive skew. The eye contralateral to the lesion is lower. It reflects imbalance in vestibular tone in the roll plane.
So careful analysis of skew, torsion, and associated signs provides valuable localization information pointing towards vestibular pathway disruption. Let's shift now to eyelid abnormalities. Ptosis or drooping eyelid is common. What are the main categories of causes?
Ptosis can be broadly categorized as neurogenic, myogenic, mechanical, or senile, involutional.
Neurogenic causes.
That would include third nerve palsy, often severe ptosis, affecting the levator palpebrae muscle, or Horner syndrome, milder ptosis, affecting Mueller's muscle via sympathetic nerves. Myasthenia gravis is also neurogenic at the neuromuscular junction level, causing fatigable ptosis.
Okay, myogenic.
This involves a primary problem with the levator muscle itself, like the congenital ptosis where the muscle didn't develop properly, or in various muscular dystrophies like oculopharyngeal dystrophy or myotonic dystrophy, or mitochondrial myopathies like CPEO.
Mechanical causes.
Anything that physically weighs the lid down or prevents it from opening properly, like a large lid tumor, swelling, scarring, or even just ill-fitting contact lenses sometimes.
And senile or involutional ptosis.
That's very common in older adults. It's due to stretching or detachment, dehiscence of the levator aponeurosis, the tendon that connects the muscle to the eyelid structure. The muscle itself works fine, but its connection is weak.
Okay. What about the opposite eyelid retraction, where the lid is held too high?
Eyelid retraction, seeing sclera above the iris, upper lid, or below it, lower lid, also has several categories of causes.
Neurologic causes.
Collier's sign, the bilateral lid retraction seen in dorsal midbrain Perrineau syndrome, is one. Contralateral lid retraction seen with ipsilateral ptosis in the plus-minus lid syndrome we discussed with third nerve nuclear lesions. Also, aberrant regeneration after a third nerve palsy can cause the lid to retract bizarrely on downgaze or adduction.
What about endocrine causes?
Thyroid eye disease is probably the most common cause of bilateral and sometimes unilateral eyelid retraction. It's due to inflammation, fibrosis, and shortening of the levator muscle, and also sympathetic overactivity. Graves' sign, lid lag on downgaze, and Stellwag sign, infrequent blinking, are associated signs.
Neuromuscular causes?
Myasthenia can sometimes cause lid retraction, paradoxically. It's also seen in certain periodic paralysis syndromes or myotonic conditions.
Myogenic or mechanical?
Lid retraction can occur temporarily after botulinum toxin injections for facial spasms if it affects the orbicularis oculi. It can happen after eye surgery. And anything causing globe prominence or proptosis, bulging eye, can mechanically cause the lids to retract. Table 8.2 in your list lists causes of proptosis.
Any other causes? The text mentions liver disease.
Yes, the Summerskill sign of bilateral lid retraction in liver disease has been described, though its reliability is questioned. Sarcoidosis can also sometimes cause lid retraction. And of course, people can voluntarily retract their eyelids, usually bilaterally and with brow furrowing.
Lid lag, where the upper lid lags behind the eye on downgaze, is that just part of retraction?
It's often seen with eyelid retraction, particularly in thyroid eye disease, Graves' sign, but can occur with other causes of retraction too.
Briefly, what about ectropion and entropion?
Ectropion is when the eyelid margin turns outward, away from the eye. Common causes are age-related laxity, involutional, paralysis of the orbicularis oculi muscle from facial nerve, CCNZSA, cicatricial, or mechanical cause like a tumor pulling the lid down.
Okay. And entropion?
Entropion is the opposite. The eyelid margin turns inward, causing the lashes to rub against the cornea, which is very irritating. Causes include involutional changes, lid laxity plus overriding muscle, muscle spasm, spastic, scarring of the inner conjunctiva, cicatricial, congenital factors, or sometimes an ophthalmos, sunken eye, leading to mechanical entropion.
Okay, that covers a wide range of ocular motor and related abnormalities. We've journeyed from diplopia types through testing, specific nerve palsies, pupillary pathways, supranuclear control, saccadic disorders, gaze palsies, skew deviation, and finally, eyelid issues. It really highlights how intricately the eyes are wired into the nervous system.
Absolutely. The sheer number of distinct clinical syndromes arising from lesions in different parts of these pathways is remarkable. It underscores why a detailed examination of eye movements, pupils, and lids is such a fundamental part of the neurological assessment.
We've covered an immense amount of detail today, really following the systematic approach laid out in our source material. The key takeaway seems to be that the specific pattern of abnormality, which movements are affected, under what conditions, associated signs like pupil changes or lid position, whether it's comitant or incomitant, provides invaluable clues for localizing the problem, whether it's in the orbit, the muscle, the nerve, the brainstem, or even higher cortical centers.
Precisely. It's like detective work. Each sign and symptom is a clue, and putting them together allows you to narrow down the possibilities and often pinpoint the location and sometimes even the likely cause of the neurological or ophthalmological issue. Careful observation and systematic testing are paramount.
It really makes you appreciate the complexity behind something we do constantly without thinking, just looking around. Those constant, subtle adjustments your eyes are making every single moment are a testament to this incredible neural machinery working tirelessly behind the scenes.
Yeah.
And how even slight disruptions, a bit of double vision or a subtle gaze limitation, can signal a much deeper story unfolding within the nervous system. It certainly encourages you, the listener, to perhaps explore some of the specific conditions we mentioned today, like INO or Paranas or the different nerve palsies in more detail if they sparked your interest. There's always more to learn.
Definitely. Each of those could be a deep dive in itself.
Indeed. Well, that wraps up our exploration for this session. Thank you for joining us on the deep dive.